Okay, now I'm back. So we will continue with the management. All this more to rhinosinusitis and the management. So first, I show you the video of, I think everybody knows about all this acute rhinosinusitis and chronic rhinosinusitis. So this one is acute rhinosinusitis. We can see this patient has deviated nasal septum and high DNS. And because of that, it push everything laterally. So this patient prone to have rhinosinusitis, whether acute or chronic. So this one is acute rhinosinusitis because we can see pus that trickling down from the medium meatus or osteomeatal complex. And in this type of patient, we try oral antibiotic first with all that nasal corticosteroid therapy and decongestant, all that. Is failed, then we admit the patient to the ward. We give IV antibiotics. Okay, that's roughly. And then now we go. This one happened because we go back of the osteomeatal complex, kan? Because everything is blocked. When everything is blocked, so the secretion cannot drain into the osteomeatal complex, so it's retained in the maxillary sinus lower part. So that's why we can see the stagnant of secretion in the lower part of the maxillary sinus. Okay, this one is chronic rhinosinusitis. I think without nasal polyposis or with nasal polyposis. This one is chronic rhinosinusitis with nasal polyposis. Yeah, we can see the polyps, and polyps sometimes allergic polyps, right? You can see like yellowish. It can be allergic fungal rhinosinusitis, or it can be chronic rhinosinusitis with nasal polyposis. It depends on the Kuhn and Band classification, right? So if we take all this, but it looks like yellowish in color, I see this. For me, it's more to allergic fungal rhinosinusitis, and I will do all the tests to meet the criteria by Band and Kuhn's. Okay, so we can see this. When we have nasal polyposis, it will block the osteomeatal complex. So the aeration of the maxillary sinus both sides is impaired, and also the aeration of the anterior epithelium is already impaired. Yeah, because block is at the osteomeatal complex. I think I missed one slide. Yeah, actually the other one is chronic rhinosinusitis without nasal polyposis. It's okay. All right. So the chronic rhinosinusitis without nasal polyposis, patient have symptoms of chronic rhinosinusitis, but there is no polyp. So actually, the treatment is little bit only different, but I will show you later. So the treatment, we can have a medical therapy. All patients with chronic rhinosinusitis with or without nasal polyposis or acute rhinosinusitis, the first line must be medical treatment. If they fail medical treatment, or if they have complication of the rhinosinusitis, then you start to do surgery. Okay. Okay, so medical therapy for acute rhinosinusitis. The first one, we give alkaline nasal douche or normal saline irrigation. There's a different little bit because alkaline, you have a sodium bicarb. But normal saline, you don't have the sodium bicarb. Actually, it's almost the same. We give interchangeably. Sometimes I just give a saline irrigation. Sometimes I give alkaline nasal douche. Alkaline nasal douche is like free. We can get from hospital. But normal saline, we have to buy that. You know, you have Nilmed here. So Nilmed the same. Nilmed, and then it's basically this nasal irrigation is very good because it removes the mucus blanket or with that track all the secretion, debris, and all that. And if patient have crusting, then it will clear up the crusting. And the most important thing is because they improve mucociliary clearance. That's good because they have salt, right? Sodium bicarb, and the other one is that garam lah, salt. Okay, and then the number 2 is oral antihistamine. Is patient have allergic rhinitis. Yeah. And this one is because I follow the guideline, the EPOS guideline, and also because we develop our own guideline in the treatment of rhinosinusitis. Sometimes we give corticosteroid in patient with acute rhinosinusitis. Yeah, even though it's acute, sometimes we give, but I didn't give all the time. I give more to antibiotics rather than corticosteroid in patient with acute rhinosinusitis, because we know that if a patient have acute rhinosinusitis, they have infection. The one that we worry, when we give the steroid, it lower the immunity of the patient. So it will spread the infection into the bone. That's why, like, we want to give the corticosteroid oral, then we have to balance. Topical, yes. Topical you give, but not oral. Topical is like included in the course of treatment of acute rhinosinusitis, but not oral. Okay. The antibiotics, usually the patient who come to us, they already treated by primary health care center or from private. So when they come to us, we give a second line antibiotics, is augmentin or zinat. If patient fail, all this oral. If patient fail, after 1 week, they come to us. If the symptom is not resolved, then I will give a third line antibiotic. That one is Everlox. Yeah. If they fail Everlox, then patient will be admitted, and then we give IV antibiotics original. Yeah. And once everything is settled, patient go home. If patient had have infection a second time, then we will plan surgery already. Yeah. If means when patient, let's say this time patient discharged because everything settled, and then I can see lah all these what we call that, the anatomical variation. Got concabulosa lah, got all this, all that. So the thing is, I give a chance to patient. That means if patient come a second time with the same infection, I will give antibiotics again, all the batteries of course of antibiotic, corticosteroid spray, topical. But that time, I will plan for surgery. Once everything settled, the patient is already post for surgery. I mean, maybe it takes about a month or 2 months from the second infection, then this patient must, because once it's happened again, that means the patient will have recurrent infection. Yeah. Decongestant we give, kan? Decongestant we have the topical and oral. The topical we have like there we have Afrin and Otrivin. So either one we give. The thing is, I always tell patient not to use more than 2 weeks, because patient will have rebound phenomenon. I see so many patients who has rebound phenomenon come to me with edematous mucosa, and patient has nasal block or not settled because they use the topical decongestant almost every day. Yeah, because this congestion, yes, because when you spray the nose, like us can, we spray the nose if you have like nasal obstruction, it just fast, fast release within 5 minutes already released. So patient, because patient doesn't know, something that work faster actually has a bad side effect. Yeah, so bear in mind. That's why when something in future, something or somebody come to you, oh, this one very good, and then you have to think of side effect. Yeah, so like that. So decongestant, so have to use within 2 weeks, and then have to tell patient not more than 2 weeks. Usually I don't give TDS, I give BD morning and night, because it is enough. Decongestant you cannot use a lot in a day because it causes dryness. It causes dryness of the mucosa, and you can feel in the throat, and you can feel at the back of the soft palate is very dry. Yeah. And oral decongestant, they have all these side effects. Yeah. So another one is analgesic. If patient have pain and all that, you give paracetamol or brufen and all that. But we did a systematic review. It showed that mucolytic agent and antiviral doesn't work. If you give, it doesn't work in patient with acute rhinosinusitis. Okay, these are the treatment chronic rhinosinusitis. So chronic rhinosinusitis can be divided now. Post 2020, then post 2020, they divide some more. So we have chronic rhinosinusitis without nasal polyposis, chronic rhinosinusitis with nasal polyposis, and it can be subdivided into eosinophilic and non-eosinophilic. And then another one they introduced is central compartment atopic disease. Central compartment atopic disease is mainly patient who has allergic rhinitis. So it go direct to the middle turbinate. So the area of osteometal complex, you can see the polyp is the area only. There's no polyp anywhere. There's no but they concentrate at the middle part of the nasal cavity. That's called central compartment atopic disease. You have to do all these allergy tests. Okay, so the medical therapy for chronic rhinosinusitis without nasal polyposis, you have to give intranasal corticosteroid spray. For me, I give maximum 12 months, but I will see the patient 3 times. So if I give intranasal corticosteroid spray, so I will see the patient every 4 months. So I use a visual analog score to see whether is there any improvement or not. If patient come the first time, and then I give all this medication, and then patient improve, let's say 80%, and 80 improve, let's say 50%, and the patient come to the second time, patient said no more improvement, and then the third time, if there is no improvement after the first one, so I subject the patient for surgery. Because if you wait for so long, if you delay the surgery, actually the prognosis is poor based on the study. So I give a limit for 1 year. Yeah, so if there is no improvement, 100% or 90% within 1 year, then I opt the patient. Patient choose whether they want to do surgery or not. And there I also give a low dose macrolide therapy, because this one is immunomodulatory effect. So it will work if patient have a neutrophilic more. That means if the chronic rhinosinusitis based on neutrophilic, then it will work. If eosinophilic, it won't work. Antibiotic is on the therapy is only for neutrophilic CRS. Yeah. All right. So this one is chronic rhinosinusitis with nasal polyposis. It's the same. It's almost the same. But the thing is, with polyp, we give oral steroid 4 times a year or 3 times a year. So we just repeat. This one also I give maximum 1 year. If no improvement, 80% within 1 year, surgery. Yeah. So this one the same. We give alkalinazal-duchi and we give oral antihistamine. And in polyposis also we give the antibiotic, the macrolide. This one I don't like. Patient come to me, I don't do like patient come to me, I take biopsy first and I see whether it's eosinophilic or neutrophilic, because we don't have pathologists that who want to do that, because this one is tiresome, because you have to divide. You have to divide or something like, because we have to divide and then you have to count that eosinophilic or neutrophilic. So they don't want to do. So all patients who come to me with nasal polyposis, I start both. Prednisolone I start, macrolide I start both. So if I know, if let's say after 3 months they come to me, the polyp is reduced, like from grade 1 to grade 2 or grade 3 to grade 1, that means that polyp most probably is neutrophilic. That's why they reduce. Yeah? If eosinophilic, usually it works with prednisolone. And now, because we had a study, patient who has CRS with underlying allergic rhinitis, we give immunotherapy. Immunotherapy is a new thing that they block the IgE to combine with mast cell. So there is no allergy symptom. So the polyp occurs because of allergic rhinitis. The polyp size will be reduced. But the thing is, it doesn't reduce the hyposmia. If patient have hyposmia, it doesn't reduce the hyposmia. So this one is very new to us as well. So we have sublingual immunotherapy in the form of tablet and spray. Actually, this sublingual immunotherapy, when they come to Malaysia, it is used for allergic rhinitis only. But we just add up whether we want to see whether if patient have CRS with allergic rhinitis, it works or not. Actually, it works, but it takes time because it has nasal polyp. The immunotherapy is quite expensive, about 400 ringgit per month. If we are a government servant, it's covered by grantee letter. But if we no government servant, we have to pay. It's quite a lot. And now they are talking about monoclonal antibodies, right? The antibodies omalizumab, mepolizumab, dupilumab. So the omalizumab, the company name is Xolair, yeah? And the Mepo is not there in Malaysia, but we have Dupi is Dupixent. So basically, omalizumab is introduced to Malaysia or to the world for asthma. So because asthma is like allergy component, so they look into the nasal polyp as well, and they see that actually when you give for asthma, if you have polyp, it reduce the size of polyp and reduce the nasal symptom. So that's why the company start introduced to ENT. Okay, and Dupixent actually the first is produced for atopic dermatitis, for dermatology. But now they want to see, because if patient have atopic dermatitis, they have or not allergic rhinitis. So that's why they come to ENT, because whether it can be combined or not. Yeah. This one is very expensive. About, I think about 6 months. It's 5,000 per month. Is quite expensive. So this one is management of rhinosinusitis. This one is from EPOS guideline. This one is like actually basically most of the time I just follow EPOS guideline for the treatment and just modify here and there. Yeah. So if let's say acute rhinosinusitis, we base on the visual analog scale. Kan? If there is no improvement, then you have to do all this imaging, endoscopic examination, and do culture and all that. So if patient have severe ARS, VAS more than 8, then the patient must be admitted, because it's more than that. You have to give the intravenous antibiotics, and then maybe you have to do surgery later. And if this complication is a must, you have to admit this patient and see whether the orbital complication is receptor cellulitis, you can give antibiotic first. Or if there is abscess, then you have to give antibiotic and do surgery. Okay, this one is for nasal polyposis without CRS without nasal polyposis. There's a lot. I think it's almost the same. You have to give medical treatment first. Is failed, then you have to do surgery. Yeah? And if there is a complication, then you have to go direct for surgery. Okay, this one is indication for surgery. It's nothing much. So for ARS, if no improvement within after 24 hours, then surgery. If orbital intracranial complication, you have to do surgery. If CRS, if fail medical therapy, you have to do surgery. This one management that we produce the CPG, like clinical practice guideline for Malaysia one. And this one is that I did a study that you have to do surgery or you give patient 1 year. After 1 year, if you prolong the surgery, the prognosis is poor. I think with that, thank you very much.
Thank you, Prof, for wonderful presentation. Okay, I think there is some question. Maybe I want to ask first, Prof, about the nasal steroid. You mentioned that you give for until 12 months. Yes, the topical. Is there any side effect with the prolonged nasal steroid?
It's like Nasonex, right? Nasonex,
Yes.
Nasonex.
Yes.
I miss you have it. Okay, before it's like a long ago. I don't know. Our practice, we give Nasonex and intranasal corticosteroid spray more than 1 year, maybe 5 years. But after
every
that,
day.
every day.
There is tapering off or something.
There's a certain time. We ask patient, if you under maintenance, you can use like the starting we give a spray, 2 spray, one side, BD. BD, right? And then we reduce to 2 spray, both side, daily. Okay. Once the stable, then they can do alternate. But not all the doctor ask the patient to do alternate. They have to continue the spray every day.
Okay.
Yeah. And then we did a study with ophthalmology, because we want to see is there any posterior capsular cataract, right? Because we patient on long-term corticosteroid therapy, we are worried because one of the side effect. So the study, so they follow up the patient who receive intranasal corticosteroid spray for 3 years and above. 3 years and above. So they found that the none of them got posterior capsular cataract, but their IOP pressure is increased. So because of that, ophthalmology is not happy if we give a long intranasal corticosteroid spray.
So long is more than 1 year.
More than 1 year.
Okay.
That's
So
why
because there's so many questions about that, about the side effect of the nasal steroid in the long-term nasal steroid. And the second one is about
how long will you give the intranasal corticosteroid therapy for this for CRS?
maximal is 3 months, Prof.
Oh, after stop.
We stop first
Ah.
and then for 2 or 4 weeks and then we
then
start
start.
again. Yes. Because yeah,
we give them out daily for 1 year.
daily for 1 year. Maybe
But
other specialists have any experience?
Oh, experience?
Dr. Afrina maybe in the allergy immunology?
I don't have much experience about the case.
How long to use the nasal steroid? The longest,
The longest 2 months in our
Oh, 1 year is normal.
Okay, is for every age or only certain in the for adult only, or we can use for pediatric or elderly also?
Actually, we prescribe both the same for adult and children. Patient come to us every 4 months. So every 4 months, the medication is like Nasonex. 1 bottle is for 2 months. So we give 2 bottles, so 4 months. So after finish, they come another follow up. We prescribe some more.
Is only 1 spray in the each side?
For pediatric, 1 spray each side. But for adult, is two spray each side.
2 spray BD twice daily.
For children, one daily.
Okay.
Oh, that was totally different.
Yes, we usually give Avamis, Prof.
In children.
For adult also. Because
okay.
In our government insurance they didn't cover Nasonex. So it's only for the fluticasone product.
Okay.
So we give every month actually, Prof. Because 1 bottle is for 1 month, I think.
Yeah, ever miss 1 bottle for 1 month.
Yes. Okay.
It's totally different.
Yeah, it's totally different. And the second one is about the long-term antibiotic, Prof. It's still debatable in here.
Yeah, actually, not all center give macrolide. Not all. Like in Malaysia also, like we give macrolide. USM give macrolide, but they don't give macrolide. So actually it's debatable. But because we know that a lot of study, this macrolide, if we use in nasal polyposis, it can reduce the polyp size, because some patients, they don't want surgery. So we have to give some sort of antibiotics to reduce the polyp size. So this macrolide is basically we're supposed to give for 6 weeks. Yeah, for 6 weeks. So the thing is, in my hospital, we have a macrolide generic and we have a macrolide original. So we know that the original and generic is different. So we give a macrolide original for 2 weeks. After that, we will continue with macrolide generic for 4 weeks. So altogether 6 weeks.
Okay. And then you do evaluation.
And then patient go home, come back in 4 months time, then we see whether the polyp size is reducing or not, and the symptom is reducing or not. And we give together with prednisolone. That means we give prednisolone 50 milligram daily for 2 weeks, and then macrolide for 6 weeks. Then patient come every 6 months, every 4 months.
So only 6-week treatment, and then they come back after 4 months.
Yeah, because they continue with nasal spray.
Oh, okay. When you do the steroid, the oral steroid, you still did give patient the nasal steroid or not, Prof?
Give.
Okay.
Mm.
So nasal dosing,
Nasal dosing,
nasal steroid.
nasal steroid topical,
Okay.
kan? And then oral steroid, and then macrolide.
Okay.
And then alkaline nasal douche, and then antihistamine. Yeah. If they have low dose macrolide, 250 milligram daily. Mm.
For the 6 weeks.
For 6 weeks.
For 6 weeks.
From the first week.
From the first appointment with me, I give the macrolide low dose
Low
for
dose,
6 weeks.
okay.
And then they will come another 4 months and
Uh-huh.
we see whether the polyp size is reducing or not.
Okay. What kind macrolide do you use?
Clarithromycin.
Clarithromycin, and it is rare, rare drug here.
We have clarithromycin, but it's only in the 500 milligrams here.
The original, right?
I don't know.
Because
in the
Patent.
because in my hospital the 500 milligram is original. The 250 is generic. So that's why we cannot give the original for so long because it's expensive. So we give only for 2 weeks.
Single
Five-
dose.
500 milligram daily for 2 weeks and then 250 milligram daily for 4 weeks.
Oh, I see. So
Actually, based on the
first 2
study,
weeks. Yeah.
actually based on study, you have to give 2 months.
Mm.
You have to give 2 months, 8 weeks.
8 weeks. Okay.
Based on the study lah. It's a Japanese, they start first with all this macrolide.
Okay.
Actually, they start macrolide not for nasal polyposis. They start macrolide to patient with bronchitis. They start then you see it works, and then they see that this one is more to neutrophilic. So then they start to extend to be used in nasal polyposis.
Okay.
Okay.
About the allergy, Prof, do you often use Montelukast?
Okay, the Montelukast I only give to patient who has allergic rhinitis with asthma. With the asthma, I won't give because Montelukast is like in our hospital is we cannot use like like we give Claritin. Claritin kan is like tap water give to all patients kan. But Montelukast no. So we
Okay.
give Montelukast only if patient have allergy, have asthma. That it
Asthma.
helps a lot. You give it help a lot. So some patient the exacerbation of asthma also reduce.
Yes,
Mm.
because in my experience, is patient with the allergy and have a chronic cough, it's better when we give the antihistamine with the Montelukast.
Montelukast, yeah.
Yes.
Usually antihistamine in the morning, Montelukast at night. Or Montelukast in the morning, antihistamine this one at night. Or you give only either one.
Both at night.
Both at night. Or if I give one morning, one night.
Okay.
It doesn't matter. It's
Yes.
okay.
Okay. Is there any other question? Yeah, Dr. Ayu.
Thank you, Prof. Do you have any experience for cholesteatoma in maxillary sinus?
Cholesteatoma in maxillary sinus? No. But I have seen cholesteatoma at petrous apex and removed through the nose.
Oh yeah.
Go to the
Okay.
But I don't I never experienced cholesteatoma in the maxillary sinus. No. How
Because I
cholesteatoma happen in
yes.
maxillary sinus?
I have read in the journal that that cholesteatoma exists in maxillary sinus. So it should be removed, extirpation, and if you have experience, do we have give antibiotic for long or?
If in the maxillary sinus.
Yes.
Okay, because maxillary sinus, when we put endoscopic removal, we can see everything, right? And then we can scrape the mucosa. It's not the same as if cholesteatoma in middle ear. Cholesteatoma in the middle ear is difficult to remove. You cannot scrape the mucosa that lining the middle ear. That's why sometimes the cholesteatoma in the middle ear, it tends to recur. Because sometimes it's difficult to remove totally because the area is very small. But in the maxillary sinus, you can do the medium maxillectomy and remove everything, or take out all the mucosa, and it won't recur. Usually it won't recur because you remove everything. That is different because the space is very big.
Yeah, thank you, Prof.
Okay, is there any other question? Yeah.
Thank you, Professor, for the opportunity. I want to ask about middle meatal antrostomy. While we perform middle meatal antrostomy, how large should we open the ostium? Because sometimes after the procedure, the stenosis will occur, and will it impact the mucociliary drainage?
Drainage.
Thank you.
Okay. The medium yet, because we have, if you open up the ostium, they have a different type of name. So if medium meatal antrostomy is a normal that we do. And they have a modified medium meatal antrostomy. And they have a mega medium meatal antrostomy. This each one is different. So the one that we usually do is normal medium meatal antrostomy. I want to draw a medium meatal antrostomy is normal because the boundaries of medium, if you can imagine the normal medium meatal antrostomy, the boundaries anteriorly is uncinate. No, anteriorly is the frontal process of maxilla. Posteriorly is the perpendicular plate of palatine bone. Inferiorly is the inferior turbinate, and superiorly is the floor of the orbit.
Maybe you can show the slide, Prof. Your previous slide. Yeah. Itu bisa kok pakai gambar, pakai ini aja.
It was already. No, inside this one. This. Or maybe can I share screen? Share screen again. Share screen. Okay, all right. Okay. So, okay, medium meatal antrostomy is normal. Medium meatal antrostomy, that means medium meatal. The process, anterior boundaries is frontal process of maxilla here, right? And then superior boundaries is the floor of the orbit. The inferior boundaries is the inferior turbinate here. And then the posterior boundaries is the palatine bone. This palatine bone, actually for MMA, you cannot remove the palatine bone because once you remove the palatine bone, it's become mega. If you remove the palatine bone here, you will flush with the posterior wall of the maxilla. When you flush with the posterior of maxilla, it's become a part of mega. It's part of mega. And then you have to remove both fontanelle, anterior fontanelle, posterior fontanelle, make a single cavity. And then the uncinectomy or superior limb, inferior limb need to be removed. When you remove the inferior limb, then the floor will be the inferior turbinate. That one is medial meatal antrostomy. Okay. Modified medial meatal antrostomy. Modified. You have to remove the posterior part of the inferior turbinate. Remove the posterior part of the inferior turbinate. Remove posteriorly, and then you have to remove the palatine bone here, and then you have to remove the floor. That means when you remove the inferior turbinate, there's a part of medial wall of the maxilla right here behind there. That bone also you have to remove, like you do medial maxillectomy, you remove right the bone down there. So the opening will be from here go till back here and down to the floor. So a big space, modified middle meatal enterostomy. If mega is like you open up everything and then you extend the inferior, remove the bone at the inferior meatus till the level of the lacrimal duct, till the level of the Hessner valve. So it extend, that means bigger and you extend like that. Inferiorly, the whole thing is mega middle meatal enterostomy. Yeah. So this one usually we do in patients with enterocoenal polyp, because in children the enterocoenal polyp is happen in children, right? Less than 18 less than 18 years old. We cannot do a massive surgery because the bone is still growing. So if we do middle meatal enterostomy, we cannot remove the anterior part of the stalk of the polyp. So you have to extend. Then you can do the lower part. But some people they do cartwellak because it's easy, kan? Cartwellak open from here, you can see that put the endoscope, you can see directly. But some people they don't want because you have a scar down there, it's painful. So we do through the nose, do modified middle meatal enterostomy if we cannot achieve with the normal middle meatal enterostomy. Question.
Any question?
I think it's better.
Oh, okay. The next question. Oh, a lot of question, Prof.
Thank you, Prof. Thank you, Ibu. I have a question. The first one is, how is your opinion about the bilateral fungal balls? Because in EPOS 2020, they said it's only for the unilateral. But when we are looking for the AFRS, the Benkan criteria, patient is only have one Mayer which eosinophilia and one minor criteria. The second question is
allergic fungal rhinosinusitis, can it happen bilateral or not, right?
Yeah.
Can it happen because before this we thought that allergic fungal rhinosinusitis must be bilateral, right? It's rare to see allergic fungal rhinosinusitis unilateral. But in the EPOS guideline 2020, they said allergic fungal rhinosinusitis can happen unilateral, right?
Yeah.
That's the question, right?
Yeah.
Okay, I asked.
How about the bilateral fungal ball? Because the EPOS is only for unilateral.
Actually, allergic fungal, allergic
Fungal ball.
He asked about the fungal ball.
fungal ball. Okay,
Yes.
fungal ball. Okay, the one that that was question number one. I answer first until I forgot the question. The question. So before this, the one that I follow from the EPOS 2012 or previous EPOS. Okay, if allergic fungal rhinosinusitis, it must be bilateral. Because allergic fungal rhinosinusitis is systemic because the IgE is high. That's why if systemic, it must be bilateral. Yeah, it must be bilateral because it's systemic. Like nasal polyposis, it bilateral because it's systemic. Yeah? So we accept that for so long. Yeah? It's like that. Even now, I cannot change that things that the EPOS change can. So and then if that one is allergic fungal rhinosinusitis. If fungal ball or mycetoma is always unilateral. Rare to see fungal mycetoma bilateral. But it can happen. It can happen. Actually like this. Actually, the common one is majority of allergic fungal rhinosinusitis bilateral. But it can happen, but it's rare unilateral. Because they study, I cannot against them. Because they study and they show that allergic fungal can occur, allergic fungal rhinosinusitis can occur unilateral. But in my practice, I've never seen allergic fungal rhinosinusitis unilateral. And anybody come across allergic fungal rhinosinusitis unilateral? Pernah, Anna? Allergic fungal rhinosinusitis? Not yet. Even me.
Yes.
I never
It's
seen.
always
Always bilateral because
Always
systemic.
bilateral.
That's why for me, kan, post 2020 is like haywire a little bit. Kan? So I don't follow the post 2020. I'm not really. I do not really follow that because I rasa it's like even though I'm one of the author, even though I'm one of the author there, but the thing is difficult to accept. Fungal ball is always unilateral. It's rare to see fungal ball bilateral, but it can happen. So if you ask me, I do not really believe the post 2020.
Yeah, we can choose partially.
Something that this one
Yes.
I follow, but something that I said against is too far away. I don't follow.
Okay. Yeah.
Question number 2.
The question is number 2 is about the bilateral fungal pulse. Because this patient is without any immunocompetence, the laboratory is only eosinophilia. This scan shows us about the fungal balls, and while we are doing this sinus surgery, we found green black ramus tissue material at the both maxillary. But the result of the pathology anatomy, they only say the domination of eosinophilia. How to manage a patient like this?
Okay, patient has fungal mycetoma,
Yeah,
and then we take biopsy,
yeah.
and they send for pathology. It come back as a high eosinophilia. It's
But-
not like fungal that normal, candida and all that. Aspergillus no more.
The microbiology is no fungal.
Maybe for me, like this can happen, but it's very rare. But something that very rare, usually I ignore because it's very rare. Anything can happen. If like because we see in the literature, can other somebody publish, it's very rare thing. It's like what? It's very rare, but it's happened like allergic fungal rhinosinusitis bilateral. It's normal majority, but it's a rare one that can happen unilateral. So for me, it's something that rare. Usually I don't take as a common or in my practice, something like that, a common thing in my practice. Like this, like fungal mycetoma, the fungal ball, and then they take the biopsy and come back as a high eosinophilia. And then you have to treat the patient with maybe patient have a high eosinophilia because other things we don't know. But the high eosinophilia, I think if we give steroid, it can control because steroid that can control to lower the eosinophilia. I think it's not, once you remove, it's not wrong to give a steroid. But if you don't remove, then it's dangerous because it's fungus. If you give a steroid in patient with full of fungus, then it will spread.
Thank you, Ibu.
Thank you for the question as well.
Yeah, in our hospital, we rarely found the positive for the fungal in microbiology examination, actually, Prof. So we usually found in the pathological anatomy or histopathological finding.
That's fungus as well.
Yes, for the fungus.
Means that the fungal, the mycetoma,
Yes,
was removed. Usually, when we remove the fungal ball, we remove the mycetoma, then we have to take the layer of the maxillary sinus
yes.
because sometimes we want to see whether it's invade the maxillary sinus or not. So both. It show
We take out the
Mucosa.
mucosa. Yes,
So
and we asked to the microbiology department, and they said there is no fungal.
no fungal. That is
But-
not invasion. No,
Yes.
actually, it's not invasive fungal rhinosinusitis. It's correct.
Yes.
But it show you see
In the histopathology, they said there is a fungus.
Ah,
Yeah. So yeah, it's usually
if okay, in HPE show fungus, but in culture no fungus.
no.
Okay. Actually, the culture for fungus is very difficult to get
Yes.
because when you take the when we take the biopsy or we take out the fungus, we cannot put the fungus on the gauze. You cannot take. We have you have to go direct to the glass bottle because the fungus it has hyphae. Once we put on the ribbon gauze and the hyphae is disappear already. It's same with me. Actually, the fungus is difficult to get through culture, through
Yeah,
CNS
culture.
kan culture. It's difficult to get. It's same. Every time we send is negative.
Yep.
But biopsy say yes because
Yeah.
biopsy is in the mucosa.
Yes.
And
Okay.
if patient has fungus in mucosa, we don't give a systemic fungal because we already removed the mucosa.
Okay.
Yeah, but if it's invade the bone, then we have to give a systemic antifungal IV
Okay.
or tablet lah if they have.
So we only need to treat his patient with the corticosteroid after surgery, or we don't need to give corticosteroid.
No
Prof?
need, I think no need.
No need.
No need.
although the histopathology said there is an eosinophilia.
Yes, I think no need because you remove everything and they see the patient follow up the patient is everything is okay or not. Because we follow up every 3 months or 4 months kan. So if let's say everything is okay, I think no need to give corticosteroid.
Oh, okay. Thank you.
I think so.
Thank you, Prof.
You said that after we remove the mucosa, we don't need to give antifungal. And then we give antifungal if there is infection in bone.
In bone.
How do we know there is infection?
Because we
in
send the bone as well.
Oh.
So because we send the bone. Because we send together with the bone because uncinate process the bone and the lower part of the
okay.
there's a bone there. We send together. If let's say if there is invasive fungal rhinosinusitis, the bone is usually is not a normal color.
Oh, okay.
If there is inside
the bone in the uncinate process not in maxillary.
in the maxillary sinus, the one that medial wall of the maxillary sinus.
medial wall.
Yeah, medial sinus. Actually, I send the bone if the bone is not normal. If the bone is normal, I rarely send as well. But if let's say because the mucosa we send, if the mucosa is involved, then we don't give because anyway we remove the mucosa already, and we know that it won't invade the bone because the bone is normal.
Oh, okay.
If I see the bone is a little bit dusky or the bone is like whitish, lack of blood supply, and I will send.
Oh,
Actually, we see intra-op.
okay.
Thank you, Prof. Thank you, Dr. Andra, for interesting
And
question.
after that, if you are not sure, can we
Yes.
just follow up the patient? Then we can see if there is involvement of the bone, it worsening. Of course, it will be worsening. But I think I never come across that patient with mycetoma. We send the mucosa. Mucosa is involved with fungus, and then I just because we remove all the mucosa and I didn't do anything. Never that in any patient that patient have invasive bone, because if invasive bone is the pathogen is aggressive. So patient will have like a lack of a sensation already once the bone is involved.
Okay. Yes. Thank you, Prof. Is there any other question? Okay. Yeah.
Thank you, Prof. Thank you, Ibu. I want to ask about the using of antibiotic in acute rhinosinusitis. When you considering give the macrolide from the acute rhinosinusitis, it is the first episode of the acute rhinosinusitis or after 3 or 4 episode of this patient acute rhinosinusitis, because you mentioned that you give the antibiotic, and then how long you give the antibiotic for the acute rhinosinusitis. And the second question is about the orbital complication. Oh,
one by one. I forgot the first question already. Okay. Okay. How long will I give antibiotic in patient with acute rhinosinusitis, and what type of antibiotics? Okay. So what type of antibiotics? In acute rhinosinusitis, I do not practice giving clarithromycin. So in acute rhinosinusitis, I will give augmentin. because augmentin cover the broad spectrum antibiotic as well, augmentin. But if I give the augmentin is, what's the name here?
In here we use the generic product, Prof. So they don't know what is augmentin.
It's like amoxicillin.
Amoxicillin clavulanic.
It's amoxicillin and clavulanic acid. So I give that. If usually if maxillary rhinosinusitis I give two type of antibiotics. One is amoxicillin plus clavulanic acid, and the other one is I will give flagyl, because maxillary sinus they have anaerobic bacteria. So I give both. Flagyl and because outside they already give antibiotics, kan? They give antibiotic, it doesn't work. So when they come to me, I will add flagyl as well. So the improvement is superb, because memang it's proven that in maxillary sinus they have anaerobic bacteria. Augmentin cover the amoxicillin and clavulanic is cover. They cover anaerobic bacteria, but the dose is little. So if there is if anaerobic bacteria is more, it cannot cover all. That's why I give flagyl is metronidazole. Metronidazole. So I give both. So I give usually for 2 weeks. It depends. I give for 2 weeks or 10 days. And then if that one is the second line of antibiotics already. So if after 10 days, patient come to me, the symptom is not improving, either I give a third line antibiotic is Avelox. Avelox is mofifloxacin, but the Avelox tablet is expensive and is difficult to get. So I prefer to admit the patient to the ward, and I give intravenous antibiotic, intravenous augmentin, the amoxicillin and clavulanic acid, and intravenous metronidazole. And for how long is usually we give for 3 days or 5 days like that, because patient don't want to be warded for so long. So if you give this like 3 days, you can see already the improvement. So once there is improvement, then you can discharge the patient with tablet. If happen second time, I dah plan for surgery next 2 weeks or 3 weeks after the second treatment.
So in the first episode of the acute rhinosinusitis, you considering using the antibiotic?
Using
the first episode of the acute rhinosinusitis, you give the antibiotic?
Yeah.
Oh.
Because the patient come to me because we are a tertiary center. They already receive antibiotic outside. That antibiotic, it doesn't work. Kan? Usually outside they give amoxicillin alone, so it doesn't work. So when they come to me, so I have to start a second line antibiotic.
But if the patient come first time in you?
First time.
He means if he practice in the secondary hospital, not the tertiary like this, what the antibiotic that you give or you suggest to give?
Okay. It depends. If your hospital has augmentin, give direct augmentin. If no augmentin, you have to give amoxicillin alone or something else. Maybe what else you have? Cefalexin is what? Cefalexin is Cefobid. It's like antibiotic that cheaper than augmentin. It actually is depend at your center. If your center has amoxicillin plus clavulanic acid, is good enough. Or if your center has Unisin is amoxicillin plus Salbactam. So if you have that, you can give. But if you don't have, give amoxicillin only enough lah. Give amoxicillin enough. And then if no improvement, then send to the tertiary hospital.
Thank you. For the second question about the orbital complication, if you have a patient with the orbital complication in acute rhinosinusitis, do you prefer the surgical first, or you give the antibiotic intravena?
Okay. If ARS with complication, pending complication, with complication, right? So if let's say this patient come to primary health care, they go to primary health care to a secondary hospital. If the doctor see this patient has a orbital complication or pending complication, they must send the patient to the tertiary hospital within 24 hours. Especially the orbit, because if let's say we cannot differentiate between the orbital cellulitis and orbital abscess, patient has only 90 minutes. After 90 minutes, patient will the vision loss cannot reversible. That's why if let's say the orbital complication is the most important one, so have to send to the tertiary within 24 hours. If let's say at the secondary has CT scan, it doesn't matter. Do CT scan first and see the level of orbital complication. Or if the patient has intracranial, patient drowsy and all that, you have to send to the tertiary hospital within 24 hours. In Malaysia, I'm not sure here how it works. Because we already we give like training of trainers we had a seminar and all that. We inform them if there is a ARS with complication, they must send to us within 24 hours. They have to call us.
Are you doing the surgery or still give the IV antibiotic?
Okay, the surgery, if intraorbital complication, we had a CT scan. So if there is pre-septal cellulitis, we give antibiotic first for 24 hours. If the symptom is not improving, then we do surgery. But other than that, the orbital cellulitis, orbital abscess, all that we do surgery with antibiotics together. If intracranial complication, must do surgery.
Thank you.
Thank you, Prof. Another question, please?
I think each one ask me question.
Yeah.
I think that you must have something, you want to ask.
Yeah.
If my student, I ask question already.
Thank you for the opportunity, Prof. I want to ask a question. We have many patients with after chemotherapy and radiotherapy develop rhinosinusitis, Prof. How to prevent it? Because the case in Karyadi a lot many. Thank you, Prof. After chemotherapy and radiotherapy, develop rhinosinusitis.
After radiotherapy, when they give the treatment, all the ciliary in the nose died. Then almost all ciliary, they won't function as normal anymore. So this patient, they tends to have rhinosinusitis. So if they have recurrent rhinosinusitis, you have to do surgery. You have to do fast, because the cilia bring out the secretion by itself anymore. Chemotherapy, maybe yes, but it's more to radiotherapy. And especially radiotherapy is because of that cilia. But chemotherapy, they has a high tendency to develop invasive fungal rhinosinusitis. So you have to follow up this patient properly, regularly. Especially when they refer or when they refer to you, patient have rhinosinusitis, then the doctor on call must see immediately, because I had experience because a case refer from renal ICU, they have like renal cancer, so receive chemotherapy. So when they refer to ENT, my registrar saw the patient, but because when she saw it like invasive or not invasive, so the treatment was delayed for 2 days. So patient lost the eye already, permanent. That's why from all this chemotherapy or all this immunosuppressive agent, it must be careful.
Okay, thank you, Prof.
Yeah, Prof. For the patient after radiotherapy, we know that the tendency to have the chronic rhinosinusitis. Is there any treatment before we choose surgery for this patient? Or is the same with the nasal dosing and intranasal corticosteroid first until 3 months, or what your suggestion?
First must follow the same thing, must do medical therapy first. If it doesn't work, then you do surgery.
Okay, so
it
it must treat
Mm.
as like chronic
chronic
rhinosinusitis.
rhinosinusitis as usual.
Okay.
But usually ciliary damage is difficult. You can reduce the symptom that patient has, but depends on the patient whether they want to do surgery or not. Unless they come to you with recurrent infection, mucopus and all that, you have to discuss with patient whether they want to do surgery or not.
Because we need to do the debridement inside
yeah.
the sinus cavity. Yeah.
Because we have to open up
Yes.
the cavity, because the cilia cannot bring out the debris anymore. When you open up, it just direct come down to the nasal, especially in patient with NPC. NPC can they
yes.
receive radiotherapy. So many patients with chronic rhinosinusitis.
Yeah, there's so many cases in here.
Mm.
The chronic rhinosinusitis after radiotherapy and NPC.
But most of the time we give a medical therapy unless they have a recurrent infection, acute on chronic rhinosinusitis recurrent more than 3 times, then we do surgery.
Okay. Okay, thank you, Prof.
Mm.
Another question?
Next.
Yeah, okay, next.
Thank you for the
What time you finish?
Have a break after 11:45, Prof?
Okay.
Yes, for the lunch break.
Thank you, Prof.
You are saved by the bell because you are the last follow.
Among several variation anatomy, which most often cause rhinosinusitis?
Sorry.
Among several anatomical variation, which most often causes rhinosinusitis?
Anatomical variation. Okay, the anatomical variation not necessarily causes rhinosinusitis. I mean, if you have anatomical variation, you must have rhinosinusitis. No, because the study was done, not all anatomical variation can arise. That can cause rhinosinusitis. No, because they based on the study through EPOS as well. EPOS, I believe in EPOS 2012 rather than EPOS 2020. Yeah. So they did a study on anatomical variation. They found that which one? They found that deviated nasal septum, I think, when they compare, it's not significant. Actually, it's not significant. That means not all anatomical variation can cause rhinosinusitis. Are there something else that trigger that patient can cause rhinosinusitis? It's not because of anatomical variation alone. But no study done. What that caused, the external factors, maybe the external factors, the irritants and all that can cause edema of the mucosa and that cause rhinosinusitis. But the anatomical variation itself actually is not 100%.
Thank you, Prof.
There must be another trigger factor. Yes. Okay. Thank you, Prof. Maybe we have to take a break first. And one question again, Prof. Is it okay for you?
Sorry, Prof.
Okay. The last question for this session, we will continue after lunch break.
Okay, thank you. Prof, maybe the last question. According to EPOS, we know that
I can
CRS.
see you. Okay.
According to EPOS, we know that CRS is divided into eosinophilic and neutrophilic, according to this biopsy. But sometimes we found that pathologists they can conclude whether this is neutrophilic or eosinophilic because they found a mix whether neutrophil and eosinophil at the same time. So how we treat post-operatively whether this type 1 or type 2?
Okay. So okay. When I publish a paper on eosinophilic and neutrophilic, actually you know Professor Richard Harvey? Professor Richard Harvey he did a lot of study on this. And then he told me that you cannot divide the polyps into eosinophilic and neutrophilic. You have to divide the polyp into eosinophilic and non-eosinophilic. Yeah. So the eosinophilic is okay. It's memang you can use prednisolone. But under non-eosinophilic, it is a lot. It's neutrophilic. Plasma also is under, plasma cell is also under neutrophilic. Basophil cell is under neutrophilic. So that's why we cannot group this polyp based on the that cell only. So you have to group into eosinophilic and non-eosinophilic. Do I answer your question? Yeah. Yes. No, no. Oh.
The histopathological finding didn't conclude is it eosinophilic or not eosinophilic because it mixed up. So how to make conclusion?
Okay. Because we are not sure which one. That's why in all patients we can give both. Prednisolone you can give. Here if you practice macrolide also you can give because sometimes it's equal. But we did a study in Malaysia is 46% of nasal polyp is non-eosinophilic. So that's why I give both. So I give both. I cover eosinophilic and I cover the non-eosinophilic as well.
Okay. Is that
Yes,
the
thank you.
question?
Yes.
Do you have any question?
No, only one.
Last question with his question, Prof. So if we found that there is eosinophilia in the blood count and there is not non-eosinophilia in the histopathological finding, which one we use, Prof?
Okay. If like it's like in the world, they say that we have to use a local. That means we have to use the one that polyp because blood eosinophilia, it doesn't mean the polyp eosinophilia. The treatment is based on local. That means if you take the polyp is eosinophilia, then you treat based on that. Even for allergy, now they talk about local allergic rhinitis, right? They start to brush the
nasal,
epithelium and then take the biopsy because they say that the local is more give impact if you give the treatment or compared to systemic.
Okay. Thank you, Prof. Please give applause to Prof. Salina for her marvelous talk. Okay, now we will have a lunch break and we will continue at 1 p.m. Okay, thank you. The next session will be case discussion and maybe another question from President or from all the participants. Okay, thank you.